Patient brought to emergency, unconscious, no history available. Attendants panicking. What will you do first? Altered sensorium is not a diagnosis. It's a symptom of something life-threatening. Hello viewers, myself Dr. Muki presenting you with another video on how to approach a patient of altered sensorium in emergency room. In this video, I'll teach you a systemic step-by-step approach that can apply immediately in the ER. Watch till the end for complete understanding. Let's begin. Step 1. Always approach with ABC first. Before thinking about causes, think of survival of the patient. For A is airway. Is the airway patent? If GCS is less than or equal to 8, consider endotracheal intubation and then look for secretions, vomitus and tongue fall. For B, breathing. Check respiratory rate to rule out tachypnea. Check oxygen saturation to rule out hypoxia. And check ABG if needed to rule out alkalosis or acidosis. And for C is circulation. In circulation you have to check for pulse rate, volume, rhythm. Then go for blood pressure if the patient is hypotensive or hypertensive. Make sure to access the IV line and start IV fluids if the patient is hypotensive. Remember, many patients improve just by correcting hypoxia or hypotension. Let's talk about the step 2, which is quick reversal causes. Never miss these causes. In emergency, always rule out the hypoglycemia, which is a most common cause for altered sensorium. Check RVS level immediately. If it's low, give IV dextrose like 25% dextrose or 10% dextrose. If the patient is hypoxic, if the oxygen saturation is low, give oxygen therapy. If it's opioid overdose, there will be pinpoint pupils. Then give injection naloxone. If it's seizure or post-ictal state, give antiepileptic. Because these are all reversible causes. Treat immediately. Treating the cause will reverse the condition of the patient. Then step 3. Assess level of consciousness. So to assess level of consciousness, we have to check GCS. That means Glasgow Coma Scale. In a different video, I'll talk about the GCS later on. So in GCS, we have to check for eye opening, we have to check for verbal response, we have to check for motor response, and document GCS properly. This is a medico-legally important. Then step 4. Then differentiate structural versus metabolic causes. So this is where your clinical skills matter. In structural causes, that means in brain problem, the altered sensorium are maybe due to stroke, intracranial hemorrhage, any tumor in the brain or any trauma. And what are the clues for structural causes? You will get like unequal pupils. Then there will be focal neurological deficit, and there will be abnormal posturing of the patient. The posture of the patient will be very abnormal. Then what to do? Then do urgent CT brain to rule out the neurological problem. That means to rule out the structural cause, go for CT brain urgently. So next come the metabolic causes. That is a systemic problem. So what are the metabolic causes that can also cause altered sensorium? First is uremia. Second is hepatic encephalopathy. Third is electrolyte imbalance. Fourth, sepsis. And last one is the thyroid storm like myxedema. Usually there will be no focal deficits in metabolic causes. There will be focal deficits in structural causes, but there will be no focal deficits in metabolic causes. And there will be symmetrical findings. The findings will be symmetrical. Let's talk about the basic investigations to done for a patient with altered sensorium. If you receive a patient in your ER with altered sensorium, order immediately with CVC, RFT LFT, electrolytes, AVG, serum ammonia if you are suspecting of liver diseases or if you suspect the patient is a chronic alcoholic, and then toxicology screen if required. These are the minimum investigations to be done for a patient with altered sensorium. Also you have to do like RVS and CT brains. Now, what are the red flag signs in altered sensorium patient? So if the GCS of the patient, the Glasgow Coma scale, is dropping, then it's a red flag sign. If there is unequal pupils, it's a red flag sign. If the hypotension is persistent even after correcting the dehydration or even after giving the IV fluid, it's a red flag sign. If there is signs of raised intracranial pressure, it's a red flag sign. These patients need ICU treatment and care immediately. Never keep this patient in ER. So what are the clinical PRs? So if you remember nothing else, if you forgot everything, remember this. Just remember this. Always check blood sugar level before CT scan, because hypoglycemia can mimic a stroke. If you found this video helpful, share it with your junior colleagues and residents. And kindly don't forget to like, share and subscribe my channel. And watch my next video on approach to coma in 5 minutes. See you in my next video. Thank you so much. Thanks for watching.